So I had a bunch of questions, of course, because we have been working on this topic for the last day and a half, let's say, but there has been a lot of preparation before. So of course I'm a scientist, so I have a lot of questions. Given the time that is remaining now and before we want to close, I'd rather welcome discussion and question coming from the audience. And also I was interested to know if among our guests, there was maybe some question that you wanted to ask each other, because it would be interesting to have your feedback as well as not only as an expert regarding your own field, but maybe your own question regarding other experts' field. So I just open the discussion and I will be the timekeeper. So forgive me in advance if I'm a bit harsh and I say, stop, we need to stop. So please, first question.
Okay, Rick Mattis, Purdue. I'd like to ask one question about stimulus and one question about the consumer and get people's reaction to it. So there's a pretty substantial literature now showing that for salt, for fat, and less compelling but still directionally consistent for sugar, that the preferred level of the sensation for each of those is determined more by the sensory exposure to them than their metabolic effect. That is, if you put people on high salt or low salt diets, high fat, low fat diets, and you either restrict or allow access to the mouthfeel of those sensations, it's the exposure that determines the preferred level, not the metabolic challenge that's posted to them, which says to me that there's nothing super normal, super special about them. It's experience. You like what you're exposed to, what's familiar to you. And I think that's an important point, because a number of you have talked about a special property of salt, fat, and sugar that might be driving this. So I'd like your reaction to that. And second, in terms of the consumer. So my understanding from reading the literature is that in general population, the Yale food addiction scale would indicate that something on the order of 5% of the population would be classified as food addicted. The incidence of overweight and obesity is about, 65%. So we're talking about a very, very small proportion here. Plus, note that the people who are obese aren't gluttonous, right? Most people get there by gaining a half kilo to a kilo a year. And I think when we talk about addiction, we're thinking about some kind of overconsumption that is really remarkable. And that just doesn't seem to fit with the data. Plus, weight gain, even in the obese, is not steady, right? There are long periods of time where their weight's stable, and then there's a bump up, and then their weight's stable again. So are they becoming addicted and then unaddicted, and then addicted and unaddicted? It just doesn't seem that we've gotten there. So we've had speakers say that it's not related to obesity, that it's related only to a subset, maybe binge eating disordered individuals, and then others making more global claims that it's related to the obesity epidemic. Could you speak to that?
I can start with the second question and leave the first one to someone else. So I think it's important to distinguish between someone who is addicted and the impact of an addictive substance on public health. So with every addictive substance, only a small percentage of people, 5 to 10%, become fully addicted. If we only focused on that small sliver of people, we wouldn't in any way be capturing the actual public health cost, especially when an addictive substance is legal, cheap, easily accessible, heavily advertised. And so most people consume an addictive substance and don't become addicted, but do overconsume and do have a tendency at times to overindulge in a way that is more likely to occur than with something that isn't addictive. Like most people here have probably had a drink of some sort that includes alcohol and have probably overconsumed that at some point. So what our concern is that, yeah, we think that only a small percentage of people would develop a full-blown clinical disorder. But if these ultra-processed foods have the capacity to trigger an addictive response, most people would show a subclinical level of overconsumption of these substances, to the point on a public health scale would be very, very concerning. And from everything we know about addiction and public health, I think that's pretty consistent with what we see with other addictive disorders and drugs.
I could just provide a brief answer to the first question, which is what determines the preference. So if you do sham feeding in, for example, rats, then you find that you get the preference aversion function for sucrose perfectly well when there's no food getting into the gut. So that is, as you increase the concentration of the sucrose, the consumption goes up until it gets sort of sickly sweet, then the consumption drops down. And this is absolutely essential to the sort of understanding of how rewards are guiding our behavior. Tiny quantities of substances in the mouth act as a very potent reward signal, and you need very large quantities in the gut to produce any reward. So the primary determinant of reward value is what comes into the mouth in tiny quantities. However, although that's primarily gene-specified, and fat may be gene-specified to be good because it's a calorically energy-dense substance, as is sucrose, nevertheless you can condition that preference. So post-ingestive consequences, sickness, aversion, learning, and so on, can influence the way in which our gene-specified reward systems work. But the fundamental point is the reward selection is always produced by the sensory receptors in the mouth, the nose, and so on.
I respond to that also. There's 2 points. First of all, I think that the studies that you were referring to where experience was changing preferred oral sensations. So for example, Gary Beecham's study with the salt. So one important point about that work is that the way that they were able to get preference to change so that people preferred a lower sodium soup was by decreasing the sodium content so that people were not aware of it. And so over a series of exposure sessions, from the first to the last, the preference changes, but at any individual session, the trick to getting that was not having them aware of the differences in the sensory property. Now, the reason I think that that is important goes back to the question why I think that it is, at least for carbohydrates, and for other foods, really post-ingestive effects that may not be related to metabolic responses, that is critical, is that when we talk about oral sensations, we are talking about calorie predictive food cues. So even at the time of eating, there's absolutely, if you put something in your mouth, you're going to get a dopamine response, and the sensory properties are going to be important in driving behavior and reward, but that is because they are predictive of a positive post-ingestive effect. If you give a rat exposure to artificial sweeteners over many days, what happens is that, and the rat, especially in a hungry state, and the rat learns that that artificial sweetener is not associated with a positive post-ingestive effect, the dopamine release to that artificial sweetener goes away, and they stop consuming it. The same thing with non-metabolizable sugars. So I think the point here is that sensory information is critical in determining behavior, but the reason that it's critical in determining behavior is because it is a conditioned cue that is associated with metabolic effects or post-ingestive effects.
I may add to this a few comments that will address both questions at the same time, I believe. What Dana was saying is that the salt or sugar, the first comments that were made, the processes that is at play here is a process of habituation. We learn to like what we are exposed to. Habituation, reinforcement, sensory perception, before all this, are all processes that the human machine is doing before getting to addiction, translating in reinforcement and so on. So the point I want to make is that the present emphasis on addiction may be distracting someone was saying, distracting from what's happening in society, but it is also distracting of all the other more animal processes through which the human being still at this point in time make decisions. And I think it applies to understanding. Look at salt, for instance, which is, I would argue, that potentially equal a killer than sugar. Salt, water, and maybe I may be corrected, are not addiction creating, because evolutionary basis, water was always abundant and minerals were always abundant, whether sugar, calorie were not. So the point that I want to make is that let's pay attention to the motivational reinforcement habituation process that are key to reaction to food. And addiction is different for food, addiction is different from nicotine, opium, and whatever, in the sense that it is the only one that is connected with sensory processing, metabolic, and homeostatic. And I think it's very important both in terms of what food is good and bad, but it is also important because we neglect the power of reinforcement. Someone was saying, can we educate kids, for instance? Well, maybe education is not just about educating the prefrontal cortex, which appear in the last minute of a 24 hours journey in the evolution of mind, so of man, not mind. So those are the 2 points of not jumping to addiction without understanding and considering all the steps of biological processing before we arrive to that.
I ask a question? I'm just interested in, thinking about alcohol as an example. And so alcohol can be considered something that's a drug of abuse, but it's also a food because it contains calories. So I'm just interested, what are your thoughts on alcohol in this type of discussion?
Maybe I would transfer this question to Dr. Hall, in the sense that you're right. Alcohol, maybe some aspects that you get some of the sensory aspects, but still the whole complexity of alcohol in terms of the multi-dimension and so on is much, much less complex than it is for food. But I do not claim to be expert in the biological, so maybe Dr. Hall, you may want to address further.
Yes, I don't know a lot actually about alcohol and addiction, but it's obviously not driving intake because of the energy that one gets from it.
It happens that the genetics of alcohol are one of my hobbies, and I can tell you this, it's very interesting because first of all, the concept of addiction is as an illness for human beings, it's among the most highly driven by genes, strongly genetic. And you know from your friends that alcoholism runs in families and tends to be a chronic disease. But what we've learned is that there are many genes controlling it, and I counsel families all the time, and I tell them there are 22,000 genes approximately, and we have no idea how many genes are involved. But we do know a few things. Like some of the alcoholism in families is influenced by variants of the opioid receptor, the mu-opioid receptor, and this is really interesting because it influences the response to opioids, to response to pain, and mother-child attachment, and this is one reason why this allele possibly has been selected for over the past few thousand years. So even though this alcohol doesn't really have anything to do with the selection, but it has to do with the attachment of the child to the mother, which actually, in modern times, it has an influence on children with this allele who happen to be put in foster homes, and it changes their probability of being accepted by the foster mother. But for me, it's important as a clinician because the same allele increases the euphoria from alcoholism and makes them more likely to respond to the medication that we discovered that blocks opiate receptors and improves very much in the treatment. So you can see all of these things come together. I've become a real fan of studies of evolution because it has had an impact on my work.
I think we are going to take the next question.
Alan Galipton, New York Obesity Research Center. Speaking about alcohol, I'd like to share a scientific finding with the panel and get some feedback from you. So we observed that after gastric bypass, actually originally after bariatric surgery, in more generally speaking, patients started reporting that they were noticing that their alcohol intake was going up. We then did a formal study on this, and indeed, 2 years after surgery, there was an increase in alcohol use. And we first interpreted this as perhaps some type of addiction transfer, if you believe in food addiction, from one source of calories to another. However, we then observed that this phenomenon was limited to the gastric bypass patients. The patients getting gastric banding, which is a purely restrictive procedure without rewiring the gastrointestinal tract, did not report an increase in alcohol intake. So then our interpretation became, well, there is evidence that in gastric bypass, but not in gastric banding patients, there is more rapid alcohol absorption. So then we thought, well, perhaps this rapid rate of absorption is providing more reward. And this actually went against what I originally thought, which is that if someone is getting more reward from the alcohol, they should be drinking less. But in this case, it seemed to fit the data. So our group and another group, King et al., published similar papers with the same findings. So I have two questions for the audience, for the panel and the audience as well. Do you agree with our interpretation that this could be due to faster absorption of alcohol? And the second question is, this phenomena only occurs 2 years after the surgery. Why doesn't it occur 1 year after the surgery? Those are my questions. If anybody wants to take a crack at it.
Well, I think one of the possibilities here is exactly what you are hypothesizing. With some other addictive compounds, the more rapid absorption and the more rapid that a peak blood level goes up, the more addictive those substances can be. In terms of what the time period is, during the immediate aftermath of Roux-en-Y gastric bypass, getting a large amount of calories into the intestine quickly produces a very negative sensation. Looking at patterns of food intake following surgery at about a 1 year time point, on the amount of food that's consumed does tend to go up significantly. And it may be that there's just some kind of an adaptive process going on in terms of the system getting used to that kind of a more rapid caloric delivery.
I'm not going to have anything that meaningful to say, but I think the case of gastric bypass is probably more complicated on several levels. We know that there are lots of endocrine changes that happen fairly early, even before there's weight loss. And my guess is there's actually a lot more happening over those 2 years that we haven't adequately covered. And the only piece of data I want to offer is there were a couple of studies published, I think, in the last couple of months that show an increased suicide risk in patients who underwent gastric bypass surgery, not just bariatric surgery per se. And I think that speaks to probably more pathologies than just what's happening in the gut or with substances. So my take would be that actually it is probably far more complex, but there are probably other players there too.
Thank you. Next question.
Thank you. Caroline Smith-DeWall with the Center for Science in the Public Interest. I'm also a member of the Food Forum. I want to move the discussion a little bit back to the food environment. In the US, we take a healthy population of 18, 19-year-olds. We move them to an environment, a university or college campus, where there is a controlled, there is somewhat controlled access to food. Of course, these people can walk and go get other foods, but I would be very interested, based on the research that you've done and have presented here, if your panel could give advice to college administrators on how to change the food environment. Clearly, you can't put, the high-fat, high-salt, high-sugar foods, on somewhere away where students would have to walk over hot coals to get to them. But are there some suggestions for presentation, for access, for keeping certain foods, a mile away from campus that could improve the conditions on college campuses, the food environment? Right now, there's a joke about the freshman 15. Children leave home and go to school and generally gain 10 to 15 pounds. And also, I'd really like to know if people think that gets reversed, or is that a part of this syndrome of excess food consumption? Thank you.
Yes.
I can answer, start to answer. I would say that's a very complex question. And it happened to be much in line with the Brain to Society I was asking before. I was talking yesterday, I mean. And with the context of, let's talk about the college environment. Yes, there are, I think someone was working on the Nudge Europe. There are ways to design choice architecture so that you take into account all what we know of human decision-making, and you reverse the fact you don't put the high sugar and fat close to the cashier, you put the apple and so on. There's a whole strategy to do there. But there is also another aspect of the economic consideration of managing your supply and demand. If you put out there all the healthy stuff and no one buy it, you are in problem. You are closing your outlet in a year or two. So that brings me to the second aspects of A and B of the second aspects. One is building demand in the individual themselves. Being to college is a very, very stressful experience. So there is a whole aspect, what I was saying earlier, of kind of nurturing and educating our youth, having in mind all the sides of the human brain and not just the knowledge. So that's one part. The other part is that at the policy and practice level, and it's done more and more, that government makes as part of their obesity or healthy agricultural policy, the institutional procurement, so that you kind of you go for those who are able to financially offer healthy food in a way that the consumer will use it. But it does require the policy, the investment. It requires working concretely in the kitchen or wherever to be able to deliver on that. So this ecosystem transformation that come at the same time as the behavioral is very, very key.
I don't think I really have anything to add in terms of how we solve this problem, but only to point out that Freshman's 15, or this situation you describe, is in a sense a natural experiment that demonstrates how body weight and eating is under environmental control, is strongly influenced by that. And there's a long history of research in that area of study by Judith Rodin many years ago who showed that American children going to summer camp would gain, or some would lose weight, and that's true in freshman 15 studies as well. And the argument there is about how this new environment differs from the previous environment the individual experienced. And similarly, I think Rick Matters earlier made the point that the trajectory for obesity may sometimes be a stepwise trajectory for individuals. And I would suggest those steps occur at when an individual undergoes a major change in their lifestyle. So, risk factors will be going to college. Certainly in the UK, it's also a risk factor for drinking more alcohol as well as it happens. But perhaps getting married or changing a job, those are times when weight change. So it shows the influences, which we all know about, but is a very good demonstration of this, the external control of that.
One of the problems, too, is that college cafeterias are completely different nowadays than they were 40 years ago, when it was a situation where you were presented a tray and you went along and you were served. Now colleges are literally competing in terms of what kind of a food environment and what kinds of extensive choices are provided, and there are no limits on what the food availability is.
There is maybe a short comment that I would like to add, very much building on the recent comments that were made. And within the context of the closing of this Institute of Medicine forum about science and evidence, what this discussion say is that the science and evidence that is needed is not just on the brain, not just on food, not just on nutrition. It is on society and on complexity. Because the same way in treating a biologically clinical disease, we know so much about human biology. We need to know so much about the society in all its complexity and connect both. So I would strongly promote the idea that the science and evidence that are needed needs to be expanded to those domains in a very urgent manner.
Thank you. We can take the next question from the virtual world, I guess.
Yes, this is a question from a webcast listener. This is from Dr. Korsan Ko from ILSI North America. If we are suggesting that addiction is a risk factor for obesity, then what weight of evidence do we need to support this hypothesis? I think they then suggest just like any other risk factor for any disease.
So I think that we're a far way off from having an amount of evidence where we can feel completely confident about the level of impact that an addictive-like process might have on obesity, as we've talked about many times today. This is a field that's still in its infancy. At this point, we have suggestive studies, but most of these studies are relatively small and aren't nationally representative and aren't longitudinal, suggesting that there is an increased risk. The largest epidemiological type study was the study published by Flint, and I'm an author on, in the Harvard Nurses Health Study. But again, that's a very different demographic. So I think where we need to kind of go is larger scale studies that are nationally representative and longitudinal, and a greater understanding of the mechanistic processes that would be at play in the same way we would with how alcohol use or alcoholism might be a risk factor for cirrhosis of the liver, or smoking might be a risk factor for lung cancer.
Thank you.
I just think we've got a long way to go in terms of several endpoints that will have to be defined before we can conduct those studies.
We can take the next question.
Yes, my name is Dr. Nancy Talavera. I'm a psychiatrist in clinical practice. I would like to ask, what do we know, or what is it know about the avoidance of displeasure rather than the pursuit of pleasure? I will argue that it's a stronger drive to avoid displeasure, like in the case of the experiment with the rats that will, risk an electric shock just to go and get that And very often, I see in patients with addictions of one form or another that they struggle with compulsive behaviors as a way of avoiding displeasure. And what is the decision-making process that occurs during that stage? Because that's when, the decision-making of choosing, a healthy food versus something that has fat and sugar happens. Do we know anything about, rather than the reward, the squirt of dopamine, what do we know about displeasure or the avoidance of displeasure and the cognitive process, the decision-making process that happens during that time?
Yeah, I think that's a really interesting point. And I want to point out that in the rat study that I showed, the rats weren't necessarily trying to avoid displeasure. They were actually seeking or willing to inflict themselves with displeasure in order to get euphoria, presumably from the M&Ms, from the foods. So I think that this sort of brings in this concept of the withdrawal data that I presented today and sort of the long-term effects of chronic overeating and what it can do and whether or not it can induce some sort of long-term displeasure that people may then try to avoid, and in doing so they may seek out food in order to avoid that displeasure that they feel. Our neurochemical studies in rats suggest that when the animals are restricted from sugar or restricted from these highly palatable foods, they will show behaviors that are suggestive that they are not very happy. They'll show signs of depression, they'll show signs of anxiety and distress. And so although they're mild, they're like what we would see in maybe, I liken it to someone who is addicted to nicotine, who maybe ran out of cigarettes and needs to wait a few hours until they can get another pack. They're nonetheless there and they're present. And so I think this does raise the question of, is this what's fueling additional overeating? Is this what's fueling them to maybe make a poor food choice next time around when they have access to food? And so I think it's a really good question and something that hopefully we can continue to study empirically.
I also have a sort of thought on this. So after you've computed reward value or pleasantness, you then need to go on to compute economic value, how much one would pay for something, in a sense. So one has to work out the sort of net reward minus the cost for a particular stimulus in the environment. And then it's those net values, which we're starting to work on in the brain, that are then the subject of the choice. Now, each person will, as I was arguing, be having different weightings because of their different initial setup genes and so on, for different rewards and different costs. So everyone's going to have slightly different reward-cost functions to produce economic value. Then even apart from that, when people take decisions about value, some people take a decision for the short term, for example, how much money they might get in the next half an hour, and others are willing to save for the future. And it turns out that there's a genetic correlate of that in how impulsive one is in the choice. And that's also reflected in which bits of the brain are actually taking those decisions, whether it's a rational bit that can plan for the future or something that's more influenced by the current state of affairs, how nice something is. So the whole field of neuroeconomics is just starting to think about exactly those issues, about how you take into account benefits and costs and how they're traded off.
Perhaps I could follow that up, this notion of delayed discounting, I think, what's being discussed here. So the attractiveness of eating this chocolate right now is not overridden by the fact that I think I might get heart disease in 20 or 30 years' time. It might be overridden by the idea that it's going to cause me to put on a few pounds in weight in the near future. So that's what's being suggested by some people in the UK, for example, at the moment, the idea that we should encourage healthy eating through appearance-based interventions. Eating healthy will make your skin look better. Another thought that we've had in Bristol is to think about more closely about the sequence of events that some of us experience when eating perhaps forbidden or naughty foods. which is to anticipate not only how pleasurable that's going to be, but anticipate the regret we might have soon after eating that food. So this, in a sense, this is a form of cognitive behavior therapy. I think I'm not really suggesting anything very unusual or special here, but there's a whole, I think we need, it's worth looking at our experience of eating and the experiences of just after eating, and seeing how we might use that to help gain control of what we might perceive as problematic foods. And that's also about top-down influences as well. We had an experiment where we labeled chocolate in terms of its some possible health aspects, its cocoa polyphenols and so on, versus indulgence. What we found is that when people ate that chocolate, they labeled their feelings of fullness rather differently afterwards. So if it was labeled as indulgent, they felt very much more negative about the same level of fullness afterwards. So there's really rather subtle effects that we have in relation to eating that we could perhaps use to help gain control of some problematic foods.
So last remark, and then we close down the session.
So I think the question you were referring to was about what George Koob calls the dark side of addiction, that where you move to the stage where you're taking drugs to avoid basically your negative reinforcement. And I think he's also written about that exact same area with regards to food addiction, a paper in Physiology and Behavior 2011. And I think that's an interesting idea to consider here, because while withdrawal may be one part of the problem, withdrawal is not the only negative effect you have when you're not taking drugs. And I think that's very telling from the studies of drugs like cocaine, where you don't have prominent physical withdrawal, but there is still a lot of negative feelings of different kinds that are being ameliorated by the continued drug seeking. And that's probably a very relevant thing to consider for something like food too, that there are a multiplicity of factors involved. The biology, I think, is mainly around the basolateral amygdala and CRF and stress-related systems. And it's easy enough to see a parallel there across different kinds of substances.
I'm sorry, we don't have time to take any more questions. So if Eric wants to get on stage to bring some closing remark.
I don't really have anything formal. I just want to thank everybody. I think we had a great session. I think the speakers all did a wonderful job, and I congratulate the audience as well for all the great questions and the stimulation of the discussion. Also like to thank Heather and Leslie for all the work they've done to put this all together and make this all work. One thing I would like to say to all the speakers, the IOM is going to start rolling out the information from this in different stages, and they'll get your slides out. There'll be some opportunities to get some snippets from the webcast on, and then eventually the book. And the whole thing's been just transcribed, and including the discussion. So as we get the book together, please think about what are some outcomes that we can have from this and some recommendations that we can put together and get into the book into things like future research areas as well. So thank you, and thanks everybody for all their help.